Welcome to the deep dive. Today we are laser focused on malignant melanoma. This is a high-yield, targeted revision session for all of you preparing for your board exams.
That's right. We're getting straight to the point. This is all about the critical, exam-relevant facts you need to have locked in.
We're not wasting any time. So to get the latest revision content, you must subscribe. And for our specialized journal club and clinical cases episodes, you need to purchase the premium subscription on your podcast software. Do it now.
Let's start with the absolute core. Malignant melanoma, or MM, is a malignant tumor of melanocytes. Simple as that.
Okay, let's dive into epidemiology. For the exam, what are the non-negotiable epidemiological facts we have to know?
Well, first, it's now the fifth most common cancer in the UK. That's about 4% of all new cancers. The incidence is around 20 per 100,000 people.
And that number is climbing, isn't it?
It is, and that's the key point. It's 4 times higher now than it was just 30 years ago. So the lifetime risk in the UK is now about 1 in 60.
A four-fold increase is staggering. And what about the demographics? I remember there's a distinct shift in the male-to-female ratio.
Yes, a classic exam question. In the younger age groups, say 20 to 24, it's more common in women. The ratio is about 4 to 10, male to female.
Okay.
But then it completely flips in the over 85s. It goes to 16 to 10. So much more common in elderly men.
And location, where should we be looking?
For males, the most frequent site is the trunk, that's 41%, followed by the head and neck. For females, you're looking at the leg, 39%, and then the arm.
That's vital for clinical screening. Now, risk factors. The mnemonic is P parents, right? Can you run us through that?
Sure. It's P for premalignant lesions, another P for previous melanoma, A for age, R for race, and E for economic status.
Wait, economic status, how does that play in?
It's an interesting one. There's a link suggesting that more affluent populations sometimes have more childhood sunburn, which is a massive risk factor.
Right. And the rest of the mnemonic?
N for naive, especially a large number. T for Fitzpatrick, type 1 and 2 skin, and S for sunburn or sunbed use.
And there's a specific stat about childhood sunburn that's really high yield.
There is. A severe sunburn before the age of 10 makes you 4 times more likely to develop MM. 4 times.
So how do we stratify these risks clinically? Who's at moderate versus great risk?
Moderately increased risk is about 8 to 10 times the baseline. That's for anyone with a previous melanoma, lots of moles, or organ transplant recipients.
And greatly increased.
That's more than 10 times the risk. We're talking about a giant congenital melanocytic nevus, or a strong family history of melanoma, or even pancreatic carcinoma.
That pancreatic cancer link is a key detail. Okay, let's shift to pathogenesis. It all comes down to one gene, doesn't it?
For about 50% of MMs, yes. It's a mutation in the gene for the BRAF enzyme, most commonly the V600E mutation.
In the mechanism there.
BRAF is part of the MAPK signaling pathway. This V600E mutation basically jams the accelerator pedal down. It causes constitutive activation.
So the cell just gets a constant, nonstop signal to grow and divide.
Precisely. Uncontrolled cell proliferation and survival. And, understanding this is what led to targeted therapies like vemurafenib.
And what about the role of UV radiation? We talk about UVA and UVB.
Right. So UVB is what we associate with sunburn. It's strongly absorbed by DNA and damages it directly.
Then UVA. From sunbeds.
UVA works a bit differently. It's thought to generate oxygen radicals that then in turn damage the DNA. So 2 different pathways to the same endpoint.
Let's talk about premalignant lesions. What's the strict definition of an atypical nevus?
You need at least 3 out of 5 features. Size over 5 millimeters, ill-defined borders, irregular margin and shape, variegated color, and having both macular and papillar parts.
And for FEMM syndrome, familial atypical mole and melanoma.
3 criteria for that. 1, you have 1 or more first or second degree relatives with melanoma. 2, a large number of moles, often over 50, and some are atypical.
And the third?
The moles are histologically dysplastic.
Now here's the clinical pitfall. What do you tell a patient with FAM about just removing all their moles?
You have to be very clear. Prophylactic removal does not improve survival. It's a critical point.
Why not?
Because the melanoma can arise nodo. From completely normal-looking skin, it doesn't have to come from a pre-existing mole.
That's a vital counseling point. Which brings us to diagnosis and biopsy. Let's run through the 2 main checklists. First, the ABCD rule.
Standard stuff. Asymmetry, border irregularity, color that's uneven, and diameter over 6 millimeters. And I always add E for evolving. That's maybe the most important sign.
And the Glasgow 7-point checklist.
And that one splits things into major and minor signs, 3 major ones. A change in size, a change in shape, or a change in color.
And the minor signs.
4 of them: inflammation, crusting or bleeding, a change in sensation, and a diameter of 7 millimeters or more.
So we're suspicious. What's the rule for the biopsy?
The rule is an excision biopsy. You take it with 2 millimeter margins and a cuff of subcutaneous fat. The definitive margins are decided later after the histology comes back.
Are there any exceptions? When is incision or punch biopsy okay?
Only in very specific situations. A huge lesion where you need to confirm the diagnosis before a massive reconstruction, or some lentigos that are hard to close directly, maybe a suspected subungual melanoma.
And what's the one thing you must never, ever do?
A shave biopsy or curettage. It's absolutely contraindicated.
Because you lose the depth measurement.
You make it impossible to measure the Breslow thickness accurately. And since that's the single most important prognostic factor, you've just crippled your ability to stage and manage the patient.
Let's get into that staging. For the T category, what are the key cutoffs and what's the deal with T1B?
T staging is all about thickness. T1 is 1 millimeter or less. T4 is over 4 millimeters. The really important one is T1B. That's what bumps a patient into needing a sentinel node biopsy.
And what defines T1B?
It's defined by either ulceration or R, a mitotic rate of 1 or more per millimeter squared.
So the mitotic rate has replaced Clark's level for that classification. Why the change?
Exactly. We found that Clark's level, which is anatomical depth, wasn't an independent prognostic factor once you included mitotic rate. The mitotic rate is just a much better measure of how aggressive the tumor is biologically.
Makes sense. Now for the N staging, what's the key difference between N1 and N2, and how do we define the tricky N to C category?
So N1 is 1 node, N2 is 2 to 3 nodes. The A versus B subclassification is about how it's found. A is micrometastasis, found only by the pathologist on the sentinel node. B is macrometastasis, so a clinically detectable node.
And N to C.
And to C is when you have satellite or in-transit metastases, but you have no metastatic lymph nodes in the basin.
Let's just clarify those terms. What's the difference between a satellite and an in-transit metastasis?
It's purely distance. Satellite lesions are within 2 centimeters of the primary tumor scar. In-transit metastases are the same thing, but they're more than 2 centimeters away, but still before the main lymph node basin.
Got it. So it's all about that 2-centimeter radius. Okay, on to prognosis. Besides Breslow thickness, what are the other 2 strongest adverse prognostic factors?
Ulceration, which means a full thickness loss of the epidermis over the tumor, and the mitotic rate. Those 3, Breslow, ulceration, and mitotic rate, are the big ones.
Let's run through the 4 main histological subtypes.
The most common, by far, is superficial spreading melanoma. That's about 60%. It has that characteristic radial growth phase before it starts to grow vertically.
And number 2 is nodular, which is much more aggressive.
Up to 30%. And yes, it's more aggressive because it has no radial growth phase. It just goes straight to vertical growth. And about 5% of them are melanotic, which makes them really hard to spot.
And the last 2?
Lentigo-malignant melanoma, about 7%. That arises in a lentigo maligna, which is melanoma in situ. LMM means it's invaded the dermis.
And finally,
acral lentiginous melanoma. Only 2% overall, but it's the one you find on palms, soles, and under the nails. It can account for up to 60% of melanomas in deeply pigmented and Asian skin. You have to look for it.
a crucial point. Okay, definitive surgical management. What did the big trials, like the WHO trial, tell us about how wide our excision margins should be?
Well, the margin is dictated by the Breslow thickness from that first biopsy. The landmark trials, like the Veronese and Balch studies, basically showed that there was no overall survival difference between taking very wide margins versus slightly narrower ones.
So a 1-centimeter margin versus a 3-centimeter margin for a thin melanoma didn't change how long patients lived.
Exactly. It was a huge step in reducing surgical morbidity.
Yeah.
But there's a key caveat from the BAPX Scottish trial. For thicker melanomas, over 2 millimeters, they also found no overall survival difference between 1 and 3-centimeter margins. But they found a much higher rate of locoregional recurrence when they only took 1 centimeter.
Ah, so it comes back more often in the same area.
Correct. That's why we still take a 2-centimeter margin for thicker lesions today to improve that local control.
Now for the MSLT1 trial, absolutely essential. What were the 2 core assumptions of the sentinel node biopsy technique?
The first is that we can accurately predict lymph drainage by mapping it. The second is that the cancer will spread sequentially, hitting a sentinel node before it goes anywhere else.
And what was the trial's definitive finding on survival?
MSLT1 proved that sentinel node status is the most important prognostic factor for recurrence and survival. Full stop.
Can you give us the numbers?
Sure. 10-year survival for node-negative patients was 85%. If the sentinel node was positive, it dropped to 62%. The trial also showed a survival benefit for those node-positive patients who had an immediate completion lymphadenectomy.
Okay, so what if a patient has a clinically suspicious palpable node? What's the workup?
You start with an FNAC, fine needle aspiration cytology. If it's negative, but you're still suspicious, you repeat it, maybe with radiological guidance. If it's still negative, you might have to do an open biopsy.
And you have to plan that incision carefully.
Meticulously. So it can be excised as part of the formal completion lymphadenectomy later.
Let's do a quick fire round on surgical anatomy. For an axillary dissection, what are the boundaries and nerves at risk?
You're removing nodes from Berg levels 1 to 3, relative to the pec minor muscle. Nerves at risk are the intercostobrachial, the long thoracic nerve of Bell, the thoracodorsal, and the medial pectoral.
And for an inguinal dissection?
You're in the femoral triangle, inguinal ligament superiorly, adductor longus medially, sartorius laterally, and the neurovascular structures follow the Davy Van mnemonic.
Right. And complications are pretty common with these big dissections.
Very common. Skin edge necrosis can be up to 50%, seroma and lymphedema around 30%, wound infection 25%. Okay, we're nearly there. Let's finish with systemic treatment. For metastatic disease, what are the key mechanisms we're using now?
For immunotherapy, the big one is ipilimumab. It's an antibody that inhibits CTLA-4. CTLA-4 normally acts as a brake on T cells, so inhibiting it basically releases the brakes on the immune system to attack the cancer.
And what about the targeted therapies?
That's where vimrifinib comes in. It specifically targets that BRAF V600 mutation we talked about. But there's a crucial caveat.
Which is?
You must test the tumor tissue for the V600 mutation first. If the patient doesn't have it, vimrifinib can actually stimulate tumor growth. It also increases the risk of cutaneous SCC and KAs.
A life or death detail. And what's the role of traditional chemotherapy these days?
Very limited. Dacarbazine is the main agent, but it does not provide a survival benefit. The response rates are low, 10–20%, and they don't last long. It's really for palliative care.
That's an incredible run-through. We've covered everything from epidemiology and genetics right through to surgical anatomy and systemic therapy. And if there's one thought to leave you with, it's this. Despite all the exciting new drugs and pathways, the MSLT1 trial proved that the presence or absence of micrometastases in that first sentinel node, combined with the initial Breslow thickness, are still the most profound prognostic factors we have. It all starts with that first pathology report.
That's the core focus. Now, go back and review those TNM definitions and the high-risk anatomy we just discussed. And don't forget to subscribe for the latest content and get that premium subscription for our journal club and clinical cases to keep your prep on track. Good luck.